We have the pleasure of having with us for our seminar series, Professor Thomas Payne. Tom, he's a professor of medicine and biomedical informatics and has a vast experience in clinical informatics. For 20 years, he served as medical director for information technology services at the University of Washington. And he's also past board chair of the American Medical Informatics Association. He completed his residency in medicine at the University of Colorado and an NLM fellowship in medical information sciences at Mass General Hospital at Harvard School of Public Health. He's an attending physician at the University of Washington Medical Center and Harborview Medical Center in both inpatient and outpatient care. He has been part of the history of health and biomedical informatics in the US and internationally. He has experienced the healthcare systems of multiple countries. I remember he had a period of time in the UK when they were deploying their electronic medical records. So he has many stories to tell. And as we have been tweeting, he's one of the Jedi masters of clinical informatics and clinical decision support systems. I have also a personal history. So Tom was one of the first persons I wrote to when I was looking for graduate programs to where to do my PhD. And he was kind enough to reply to that email, which is not something that happens all the time. So he was kind enough to answer my email, and I ended up applying and doing my PhD over there. So, he's also part of my story in how I got into clinical informatics. So without further ado, I would like to present to you again, Tom Payne. Thank you very much for being with us today. Everyone, please, the chat is open. So if you have questions, just shoot them there. I'll be monitoring that. And on to you, Tom. Thank you very much.
Great. Thank you so much. And I'd like to say that I've had a great time in my career, and it's included some visits to Australia, to Chile, and to many other areas of the globe where I think we've had a lot to learn, and certainly had a really good time exchanging ideas and information. So let's see if I can get the screen to behave here. And I'll need confirmation that you're seeing what I expect you to be seeing. Are you seeing my full screen?
Yes.
Yes.
Yes. Okay. Well, it's springtime in Seattle. I know that it is your fall. We have the difference in our position on the globe, and we also have difference in our time zone. And so I know by you have been getting ready to come to work, you probably haven't been as fully aware of all the exciting news that's coming out of the health IT industry. And so I thought I'd share a little bit with you, which has just got us so excited over here. If I had $1 for every time someone told me that they wish the EHR was like their iPhone, I would be a very wealthy man. And so you can imagine my excitement when I saw this on the Apple website, which I check every morning. And I cannot wait till September to experience Epic Care Big Sur, which is taking over from hyperspace. It's just going to make a difference. Epic knows so much about workflow and so much about healthcare. The design, I don't know. And Apple really brings a lot to the table with that. So we are so excited. And I'm sure you're going to be noticing this on Twitter. I hope not too much because it's not true. And if you look carefully, you'd see the clues of September 31st. And I want to give a shout out to Greg Schmidt, who made that design on the EHR that he envisions being equivalent. At any rate, someday, maybe, but not today. So this is our topic today. It's clinical support systems, and I'm giving a little bit of a retrospective view of it. I have the following objectives with you. First of all, I would like you to understand at least how I believe CDS can truly help our patients and our practitioners. And I'd like those of you who haven't had vast experience to avoid learning the hard way, or even worse, not learning at all. And lastly, my hope is that I'll help you make a difference using CDS. So to achieve those objectives, we'll talk about these topics: a quick review of the history, my assessment of where we stand today with CDS, how I believe we can increase the probability that we'll be successful with CDS in the future, and then a few minutes for summary. So my career, as Daniel said, has been intertwined with CDS. And that's one way to learn history, and that is to live it. So that has been my experience. But let's start at the very beginning. What do we mean by support, clinical decision support? Support has a variety of meanings. The one that I think is most relevant to our topic today is to assist, to help. And I will refer you to this book by Edward Schein on helping. He's at MIT, or was at MIT. Bob Sedeli gave me a pointer to this book, and I think it is a useful read for those who really honestly are interested in doing a better job helping. And that's really, I think, what we're trying to do with CDS. So let's go back to the beginning of the story, at least from my point of view. And it begins in an inner city clinic in Boston, Massachusetts, where people were treated for streptococcal pharyngitis. They first had to be cultured. And this is a strep culture, which I'm sure you have familiarity with. In those days, rheumatic fever was more common than it is today in adults. And the intent was, if your culture was positive, that you would be treated to eradicate this strep. But unfortunately, about 10% of the time after a positive culture was found, there was no treatment within 10 days of that positive culture becoming available. And so the clinic used a very early computer-based medical record system, as it was called in those days, and they adapted it to remind clinicians of this positive culture with no record of treatment. And when they turned these reminders on, the rate of incomplete or no treatment dropped almost to zero and remained there for years, as you can see on the y-axis. After that period of time, they decided they thought that the Harvard doctors knew how to treat strep throat, so they turned the reminders off. And what they found was that the rate of untreatment went right back to where it was in the baseline. And this made the point that it isn't intelligence, it's not training, it is distraction, it is being taking care of so many people at so many times. That's really what makes the difference in medicine, is being reminded to do things that you already know you need to do. So there are other ways that computing systems can help with decision making, clinical decision making, besides reminders. And here's just a quick overview of a list that I prepared over 20 years ago, and it's, I think, still fairly relevant today. One way these systems can help us is very simply to give us access to data we need to make decisions, make it easy to know more about the patient. And another shout out, this one to the AMIA decision support work group, where I posted my question about where we stand with CDS, and Jim Semino pointed out that access to prescription monitoring program is a great example of this, so that you know when you write a prescription for narcotic, if that person has been receiving prescriptions from other places for narcotics. Alerts and reminders, we saw an example with that strep throat case. Computerized practitioner order entry and order checks we'll talk about today. We can guide orders, meaning we can bring you, make you aware of a collection of orders that are relevant to the person that you're treating at the moment. We can help you review new clinical data, and if a pattern is apparent, we can bring your attention to that pattern. We can monitor treatment, such as following kidney function if you're treated with a drug that might alter kidney function. We can make it easy for you to get to external resources, and we make it easy for you to document, prompt you to remember to ask questions, to write things in the record for others to read. And lastly, we can help with aids in diagnosis. So there are a lot of things we can do that would be categorized as CDS. And I'm going to focus on a few early examples of this to start with. And the first is one of my favorites, actually, and it is from Bill Tierney and Clement McDonald years ago. And the problem they wanted to help us with is that as you order a new lab test, sometimes you aren't fully aware of the results of that same test in that same patient. So as you order electrolytes, here abbreviated lights on the left side, this system would, without any effort on your part, display the results of that very test in reverse chronological order. So you can judge whether you need another test or whether the prior results are sufficient for your need. The thing that's so clever about this is that it is agnostic to the clinical situation. So it makes a difference if this person is a trauma victim and has had their kidneys injured or fluid instilled at a rapid rate in the last hour, or whether this is somebody who's been stable for years. So your decision to order a test, what is the definition of duplicate, depends on the circumstances. This allows you to make that judgment. Very clever. Another good example came from David Ryan and Charlie Safran. This has to do with decline in kidney function. So if a hospitalized patient has a rise in serum creatinine indicating that their kidneys aren't working as well, it will alert you to the fact that the patient is receiving medications that might explain that problem, and also that there are several medicines whose dose should be changed because of the declining renal function. This message goes to the doctor. The doctor can decide what to do about it, if anything. And what was found with the evaluation of this was that it was very helpful in changing physician behavior. It prevented worsening renal impairment. It preserved renal function, and these were highly accepted by clinicians. So a great example of a very helpful alert. And a third example I'll give you in the history part of this talk is from Scott Evans in Utah, who developed this system with colleagues that helped with the problem we face with empirical antibiotic selection. And by that I mean that a person needs antibiotics, but you don't yet know the results of cultures, and yet you're forced to make a decision beforehand. So this system would help you gather the information you need and make recommendations. And it looks a little dated, but you can see here this complicated screen is divided into 3 sections. The first shows you results of kidney tests, liver tests. It shows vital signs, antibiotic allergies, the current antibiotics that the patient is receiving, and the results of cultures that have already been obtained. And in the background, it is checking the sensitivity pattern of a variety of pathogens to antibiotics in the experience of that hospital. So real-time check of the antibiogram. On the basis of that and your entry of the condition you believe the patient is experiencing, it proposes a new regimen adjusted for kidney function and liver function and for allergies, and a proposed duration of treatment. And if you like that suggestion, you push one button and that is ordered. If you don't care for it, or if you have another preference, you can change your mind. By the way, gathering this information itself, they timed how long it took people to come up with this amount of data. It took about 25 minutes. So this system was used heavily in this trial. It was used about 15 times a day, and the outcomes were very much improved when the recommendations were followed in comparison with when they weren't. It was a pretty dramatic change. Now, I must say that these three examples I've just given you are not available to me today with the commercial systems that I use. And I won't mention a lot of names, but they're the major systems in the US marketplace today. So, and you can see these are from the 90s or earlier. There has been a lot more work on alerting systems, and this slide reminds me to point out that it's not only physicians and ordering clinicians who need to be reminded. This is a picture I took out of the window of a plane taxiing for takeoff, and if you look out the window, you can see a pop-up reminder for the pilot. And in this case, it's a little disconcerting to see that we're reminding the pilot to use checklists, which I rather thought they knew to do. But again, it isn't a question of how much training they've received. They've had a lot of training. It's that they're distracted by something else, and this reminder brings their attention back to the checklist. So we've done a lot of research on these reminders, and a summary of that is shown in this slide. This is a listing of a large number of studies, and in the gray rectangle on the right, there is a vertical dotted line. The studies that had improvement with reminders are on the right of that dotted line, and the studies where there was no improvement are on the left of the dotted line. So you can see that the highest percentage of these studies did show improvement. So these were really, really well received, and they were regarded to be an important advantage to electronic health record systems. For those of you who aren't familiar with two other examples of CDS, I'm going to show you here two other examples. This is an order set. So in this case, it's designed for the circumstance when a person has had their spleen removed. And after removing the spleen, it's important to give immunizations to prevent sepsis from a variety of pathogens. And the regimen is quite complicated. And so this order set makes it easy for you to order the right things. Brings it to your attention very easily. And that's an order set. This is a timely example that came from our own healthcare system. Unfortunately, last year our community was the first in the United States to experience COVID-19 infection. We had the first case. And so we learned very quickly what to do when we see people in the office or in the hospital. And we changed what we did very quickly as we learned. So these document templates were changed several times a week in the early days, so that you can remember what questions to ask. You see, these are the classic questions. We didn't ask about taste. We didn't ask about coagulation or anything else at that moment. We didn't know about that. And then it helped you create your note quickly, order the right labs, track the conditions that the person had, and so on. And these document templates were enormously helpful to us, and have been to the globe, really, in treating vast numbers of people with COVID-19 infection. So with all of that research as foundation, we ended up, unfortunately, having a financial crisis in 2008. And in response, there was a legislation to provide stimulus, financial stimulus. And part of that stimulus was directed toward electronic health records. So this is from the law in 2010 that described the incentives for adoption of electronic health records in the United States. And highlighted in the law is a section on implementing clinical decision support. So it was very much front and center in the minds of our United States Health IT community and our political leadership. The Office of the National Coordinator was given responsibility for implementing all of this, and in their early website, they focused on the need to use electronic health records to make better decisions. This really was a game changer for the United States, and we brought together a large group of people to figure out how to do this. What were the systems going to be what we're going to incent the American medical public to use. So we brought together a large group of very nice people, very helpful people in Washington, D.C. in 2009. And they look a little younger than they do now. And there's a guy, a bald guy, still bald, standing right there. This was really quite a group. And we gave it our best effort to provide the best advice to our political leadership. And this was what came out of it, the meaningful use core objectives. And you can see I've highlighted 2 of them. Implement 1 clinical decision support rule, and the 7th one was drug-drug and drug allergy interactions. Even in those early days, there were questions about whether that was the right approach to take, but that was the best thinking of the group, and so that's what happened. So now let's move to an assessment of where we stand today. And this is a little difficult because, as I said, I'm really tied up in this, and I really still am optimistic, but I have to reflect on our current state, and it's summarized quite well by Atul Gawande in his article in the New Yorker, Why Doctors Hate Their Computers. So the word promise appears in this, and then the question is, are we achieving that promise? So it has not gone as well as we hoped that it would. Locally, I asked my colleagues what they thought about one type of decision support, which is the drug-drug interaction alerts that appear so frequently as we order medications. What do you think of these? On a scale of 1 to 5. 5 is wonderful, 1 is worthless. And one of my, a colleague that I respect a great deal, a great doctor, sent me this reply. Is there an option for -1? And so, ouch. So it just brings home the fact that these intentions are not always achieved right off the bat. And then the RAND Corporation was contracted by AMIA to understand the professional satisfaction of physicians in the United States, to know what they felt about their job, about being a doctor. And when they started this survey, they didn't ask about EHRs, but in the pilot, that came up so often that they changed the survey to include the option to talk about EHRs. And there in the list, pretty prominently, is a mention of reminders and alerts. And these were not there for a positive reason. These were considered by many doctors to be one of the reasons that their professional satisfaction is declining. So, ouch again. So then you look into the details. Why might this be happening? And here's one measure that we use. It's a crude measure, but it's one that we've had for quite some time. And this is a graph on the y-axis here of the percentage of times that when a ordering clinician is given a prompt that perhaps there's an interaction that's important, or a drug allergy interaction that's important, what percentage of the time do they override that? Do they ignore the advice and proceed anyway? The blue represent alerts for drug-drug interactions, the green for drug allergy interactions. And you can see that it's somewhere between 75 and 100% that they override these alerts. So a crude measure, but it isn't a good thing that we override 90% of the alerts. And this did not change with meaningful use. In fact, the line looks pretty close to the horizontal. There is one outlier here, I'll point out, where the override rate was much lower. Unfortunately, when this highly regarded institution moved to a commercial EHR, it went right up with the rest of us. So that's where we stand today, really. We're having a hard time with improvement. Oh, I should say, from that book, there's a tip. Tip number 4.5, minimize inappropriate corrections. If you're trying to help somebody, try not to correct them inappropriately. Well, maybe we should read that book again. So back to that screen that I showed you earlier about reducing duplicate tests, we get those alerts now, and this is what they look like. So you can see on the left, you have the time of a lab result. You have the lab results, and you have actually 3 sets of them. Here, you're told that the test is a duplicate, but you're not told anything more. So it's very hard to know whether your test is needed or not without you doing a lot of extra work by going back to another screen, canceling this order, and looking up results. So we haven't yet, in my view, in any of these systems, come to the simple arrangement that Bill Turney designed quite some time ago. All is not doom and gloom. There are some excellent alerts. This is one that I would hold out as an example. This is for reducing unnecessary testing for C. difficile, a bacterium in the intestinal tract. And this does some homework in the background, looks for results, gives you feedback. And the feedback we got on this alert was, as you see here, it was very well received. So it can be done. It is not entirely a bleak picture. So we want to succeed more than we are today. So how do we do it? What steps might we take to do a better job? And so that's what I want to turn our attention to now. And the first piece of advice I will have for you is to eat your own dog food. And that is a phrase that's very popular here in the land of Microsoft. It was popularized by Microsoft, but it started earlier. And the idea is that if you're developing a system, use it yourself. If you're developing Word, write all your documents in Word. Even though it's buggy, it's got problems, we want to make sure we feel the same experience that the other users will. And one way to do that is to dive in there yourself. If you're not a clinician, then find someone who is and collaborate with them. Another way to put this is the phrase "go to the Gemba," which is from the Toyota quality improvement movement. Gemba is the real place. So you go to where things are happening and you see what's happening there. This helps you design effectively and to change your design when it's necessary. I would propose 3 rules for CDS. The first rule is that the underlying logic should be complex enough to be as helpful as a trusted colleague. Someone that you wouldn't mind getting tapped on the shoulder by and given advice. Sometimes the logic can be simple, but often it needs to be complex so that that advice is valued. The second piece of advice is that you should look for relevant data in the same places. The automated system should look for the same data that the clinician does. So if it's not in an easy place that the vendor expects you to put it, then go look for it wherever it is and use those data as the basis for your CDS. The third is, before you bother a busy clinician who might be having a conversation about severe pain in a patient with cancer, they might be talking about their worries about declining memory. Before you bother them, make sure you're right. The logic should be complex enough to help. And this goes back to that Rind paper, just to give you a little glimpse of why that was so well received by clinicians. First of all, this is the kind of information and the logic that was built into that simple reminder that was so successful. First of all, they targeted it for adults over the age of 18. If you're under 18, that didn't appear. This was in hospitalized patients. Secondly, they only offered this in patients who had a serum creatinine less than 3. So people with chronic renal failure didn't receive this. They looked for trends. If you were receiving a nephrotoxic medication, then they looked for an increase in serum creatinine of 0.5 or more. And if you were on renally excreted medications, they look for a serum creatinine increase greater than 50% to over 2.0. Very importantly, there were stop clauses in this logic. So if there was one and then a second creatinine increase, you didn't get more alerts. It only used this logic once. And alerts were not generated more than once per admission. So you weren't getting inundated with alerts. And lastly, it was based on a very narrowly defined set of necrotoxic and renally excreted medications. So there's a lot of background work that was done, and that paid off. Now, I mentioned that we want to be sure that we don't bother a busy clinician until we're sure we're right. How do we know if we're right? Well, for that, the other tip from the book was you must always start with some form of pure inquiry. You should look things up and be informed before you move on. This is an example of where the system doesn't look for data in the places where a clinician would. This is an alert that I got and took a screen print of. And this is a little bit of a judgmental alert, I would say. It's telling me that I'm overdue for, this patient's overdue for colorectal cancer screening, and it's in red, and it feels bad to get this kind of alert because that's a very important screening to undertake. And it says overdue since 2013, but there on the right, it points out that they did have this screening, and it was an outside procedure, but the logic of the alert didn't look for that. So it's up to me to find that data and to point out that this person is actually doing well. That to me is, you do that very often, and I'm going to lose confidence in the system, and I'm going to get a little bit on the angry side. So that's something you want to avoid. Bayes' theorem comes into play here. If we want to know if we're right, then we should be thinking deeply about what being right is. Bayes' theorem is often expressed in this formula, which to me is a little bit intimidating. You look at this, a bunch of vertical bars and parentheses and fractions, and it really doesn't speak to me that well, but there was a simpler version of it, which makes sense to me, and that is this 2x2 table, where you have disease on the top, test on the left. So they have the disease or they don't, and the test is positive or it's negative. And from this simple 2x2 table, you can calculate how sensitive the test is, A over A plus C, how specific it is, D over B plus D, and most importantly, you can calculate the positive predictive value. That's what the clinician sees. They see a positive test or a negative test, and they want to know how likely it is that if the test is positive, the person really does have the disease. And that formula is here. The thing to know about this and to observe, and why Bayes is famous even to today, is that the positive predictive value depends not only on the sensitivity and the specificity, it depends on how common this condition is, what the prevalence of this condition is in that population. So prevalence is very important. So let's apply this theorem to a drug alert. And here, instead of disease and test, we have that there is an interaction that's important. That's the disease, positive or present or not. And we have an alert that appears, yes or no. And down here, we have the prevalence of the condition. This example is taken from people who have hypoglycemia, low blood sugar, when receiving 2 medications that interact to lower the blood sugar. But what you can see in studying the lower part of this is that that condition is quite uncommon. About 1,000 people out of 180,000 develop that condition. So it's quite uncommon. And this was in a group of Medicare recipients. So this is people 65 and older. So even among older people, it's a very rare condition. So that should be considered when you detect a drug-drug interaction. Is it likely to be a problem in a 35-year-old person with healthy kidneys? The data on which this drug-drug interaction is based is not in 35-year-olds, it's in older people. And even there, it's a rare condition. So you can see the positive predictive value of this alert is 4%, which is very low. So another point of optimism, we can do this. This can be done. We can make our alerts better. And this is a paper published just a few months ago from a group in actually Israel. that has a new way of creating alerts for drug interactions. And it's very exciting. And just to show you why I think they're on the right track here, you just look, and first of all, they're calculating positive predictive value. They're not sticking with override rates. They're looking at how useful this alert is to the clinician. And it's 84% compared to 4% with the control. And that's, you know, an order of magnitude higher. So this can be done. What they do is check they do their homework. They check a lot of detailed information about the patient, their age, their lab tests, and so on. And they do all that before deciding to alert. The burden of alerts is far lower also. And this is a very optimistic paper. Okay, the second piece of advice I would give to you is that you need to focus your efforts on the population that you serve. So what do I mean by that? Well, humankind is a bell-shaped curve. You know, some of us are tall, some of us are short. Some of us are wealthy, some of us aren't. And we vary in other ways too. Among the target population for clinicians, some people respond to surveys that you ask them, what do you like about these systems? Some of them don't. Some attend EHR design sessions, some of them don't. Some people even go to vendor conferences, pay their way to get there, but most people don't. On the other end, we've got people who are in the hospital on the weekend, they're taking care of our sickest patients, and they really don't spend their days thinking about EHRs. They think about their patients. Our work is to serve this entire population of providers and patients, not just these folks. And we get ourselves into trouble if we gather data only from one part of this curve and not from the other. So one way to avoid that in our studies is to use a randomized controlled trial. Randomized controlled trials are something you probably are familiar with. They are very helpful in avoiding the problem that was described by Samuel Johnson about 3 centuries ago. And I'll let you read this. It is incident to physicians, I am afraid, beyond all other men, to mistake subsequence for consequence. So he said it very well, that if there's an association between two things, that doesn't mean that one caused the other. In a slightly more contemporary way of putting this is a review published by the RAND Corporation. It was chartered by the Office of the National Coordinator, and their review of the literature, first of all, it showed that there's a great deal of evidence to support CDS, but it says the second broad theme is that with some notable exceptions, much of the health IT literature still suffers from methodological and reporting problems that limit our ability to draw firm conclusions. So it's a problem for our field. This is a graph of the number of papers in Medline with the phrase decision support in the title or the abstract. And you can see it's grown enormously. Now we're seeing the number of randomized controlled trials, and it has not grown. In fact, the percentage is far lower. Now, there's nothing magic about randomized controlled trials, but they do help. They help us avoid problems. And this is an example from the New York Times outside of health IT. So the graphs here are showing how well a Illinois wellness program worked. How well did this program affect participation in running events? Observational study says, well, it worked very well. Twice as many people went to running events. How about number of gym visits? If they were in this program, twice as many went to gym visits. How many had to end their employment because of the health? Well, about half as many if they were in this program. Program was very helpful there. Cuts down hospital spending, cuts down total spending. It really looks like a wonderful program that we should expand, until they did randomized controlled trials. And they found that there was no effect when we looked at the entire bell-shaped curve. So that's the sort of truth that these things will bring to light. If you're not familiar with how to do this, to the degree that you'd like to be, there's 2 great papers, one that goes over randomized controlled trials in EHRs, and it points out that sometimes it's a little easier to use an EHR to do an RCT than without an EHR. And for clinical decision support in particular, Ken Kawamoto and Clem McDonald, two greats in this field, drilled down on CDS and said, we need to do a better job. I think they also agree that we'll do a better job faster if we know the truth, if we know if we succeed. Now, baseball's a good example there. When you go to bat, you get 3 chances to hit that ball, unless there's a button or sometimes 4. So the point is, you don't have to hit it out of the park on your first swing. You can do it sometimes, but if you don't know if you've hit the ball out of the park, you may put down your bat and walk to first base. So when you do a randomized controlled trial, you know if you've succeeded the first time, and if you haven't, it doesn't mean you're a failure. It means that you have to refine things and try again. So randomized controlled trials let you know to a greater degree what truth is. Now, it doesn't have to be a randomized controlled trial, but it should be a thoughtful study design so that you know what truth is. And lastly, you should analyze real world effect. When you put a CDS system into place, you should go into the real world, go to the Gemba and find out what happened. And you're not done. You have to act on what you learn. So you don't leave some form of CDS in place for a decade if it doesn't work. You find out that it doesn't work, you either remove it or you fix it. And this is a good example from, again, from years ago. Susan Abacure at the Brigham was studying overridden allergy alerts. So you can see here at the beginning of 95 that about half of the allergy alerts were overridden, but a large percent of were not overridden. They were regarded to be helpful. Scroll forward, and 75% were overridden 4 years later. She discovered why. It was a particular allergy alert that was in error. She fixed it, it went back down again. So this shows that it can be done. So the tip I'll offer there is don't be offended when your efforts to help are not well received. Find out why and change it. So I'm going to summarize by listing 5 points. First of all, there is strong evidence that supports the benefit of CDS. I think we were correct as a country to incentivize adoption of EHRs and to include CDS. We were successful in encouraging broad adoption of EHRs. However, the reception has been mixed. My view is that CDS should be as helpful as a trusted colleague is when offering you advice. And to achieve that state, we need more careful design of these systems with logic that is appropriate for the problem, and we need rigorous evaluation of CDS. I think if we do these things, we can make a difference in the lives of patients and clinicians. And really, I believe that's why we are in the field that we are. So I will stop there. And if you'd like the slides and the references, there's a QR code that'll take you to them. And I want to thank you very much for the opportunity to talk on this subject today.
Thank you, Tom. As always, this was a great talk. Lots of interesting stories and insights about what has happened. And I'd like to, again, thank you for the presentation and open up the discussion for questions. And I see Brian has his hand raised. So Brian, do you want to ask your question?
Yeah, so excellent, Tom, as always. And one of the questions that I have is, you show like the alert that Bill Turney had, and then you show the alert that the vendor has created. Why have the vendors been so slow to, or have they forgotten, or are they ignorant of kind of past successes? We met with Bill Tierney once, and he kind of said it's our fault because as academics, we wanted to be pure and we didn't want to collaborate with the vendors. And the vendors won, but just kind of from a collaborative historical viewpoint, why have these results like the example you provided from Tierney and Clem McDonald? Why haven't they penetrated the larger market as well as we might hope?
Well, I wish I knew a simple answer to your question, Brian. I will say they have been busy, the vendors have been, on doing lots of other amazing things. So I give them credit for all that they've done, and they're trying to respond to my enhancement requests and everybody else's. So they have been very busy. I think, though, the reason that this early research hasn't been adopted probably falls to, as Bill said, it probably falls a little bit to us that we haven't raised that as a major issue. I think it's not a simple thing to make these changes, and they have regulatory imperatives and that sort of thing. I think also, just as perhaps the academic community had been a little reluctant to embrace vendors, I think it's probably true the other way also, that the vendors have felt that maybe it wasn't invented here, so I'm not sure that it's as important. But I'm just one voice out of many. I'm not sure I know the answer why, and I'm very hopeful that we will make more progress.
Thank you, Tom. I have another. We have another question from Joanne Manstein and Curvis. Joanne, do you want to ask the question yourself?
Oh yeah, sure. Thanks very much, Daniel. Hi, Tom. I'm a GP and I work on developing some clinical decision support, and it'd be great to be able to work with vendors more, but there's the challenges there that you've just reflected on. I'm really interested in your experience moving from a focus on individual conditions for clinical decision support to incorporate multimorbidity when we have multiple conditions with similar risk factors and similar management options, and what your approach to that might be and any challenges that you might have encountered that could guide us in our work.
Well, I would say, if I understand your point in your question correctly, there's a lot of individualization that's necessary, and people are different. Their conditions they have vary, and the combinations of conditions they have vary quite a bit. Is that your point?
Yes, and when there's different conditions that share similar recommendations but might have different targets for therapy or different dosages of drugs, and how those can kind of interact as well in a person with, for example, diabetes and heart disease and chronic kidney disease compared to a person with maybe just one of those conditions.
Right. Well, that's a hard one. And I would say most of our CDS is at a very basic level. It is not considering a lot of these interactions that occur. I'm sure there are examples where there is a more sophistication, but that's where the reasoning clinician comes in to say, a great idea, I should be using this medicine, but I won't because they've been using, this person has another condition or another contraindication to it. I would say also that the alerts should, to some degree, consider that those personal characteristics and maybe back off on the recommendation if they're present. That sometimes it's hard to know for the CDS to know that these conditions are present because it's not in an encoded form. And I'm going to give another shout out, this time to natural language processing, because often we have mentioned these conditions, or the patient has, in their notes or their messages. And if we could capture that information, we could make the alerts be more personalized and say, well, normally we would suggest that you have this medicine on your problem list, but knowing what we now know about your circumstances, we aren't going to prompt the provider to do that.
Thank you, Tom. We have another question from Megan.
Hi, thanks, Daniel. Hi, Tom. Thanks very much for that talk. I'm an academic lawyer. I work with Joanne and I'm at Melbourne Law School. I think in the work that I've done, I've noticed a sense of unease on the part of many clinicians about how the use or non-use of decision support tools might affect their legal duties and their legal risk. And I'm just wondering if this is something you've encountered and to what extent it might be an issue that affects uptake or willingness to implement these kind of systems. Thanks.
Well, that's a good question. I actually have had experience in this area. I've been an expert witness. And I'm very clear when bringing, in my opinion, forward to the jury that that these systems that we have, it relates to the first question, there is judgment on the human side that is necessary. The presence or absence of an alert isn't the final word. And so I view these as, just as the name says, support, but not mandating. Sometimes there's urging to have hard stops on these alerts, meaning you can't proceed if these conditions are true. I think that's rarely necessary or really appropriate because the system isn't aware of all of the very nuanced specifics that enter into their decision making. So I will go to bat with the defendant who is accused of ignoring the CDS unless the CDS is very reflective of the community practice standard. And there are some cases where it is. In those cases, I'll just flip it around. Thank goodness we had the CDS to prompt us, and we all have anecdotal experiences of this, that I was about to do something were it not for the CDS. And that's the best sort of outcome to have, that there was no problem at all. In summary, I don't think that doctors and nurses should worry about CDS because of the medical legal sides of it. I think they should do their professional job and regard a CDS as an imperfect assistant.
Thank you very much.
Thank you, Tom. And how do you, and I'm gonna, double dip on that question, because on the other hand, we see, and I've been fascinated by this case of Practice Fusion and the lawsuit that they had to settle because they were, they colluded with the drug company to insert an additional option into their opioid prescription CDS system. And there's an estimation that the alert triggered about 230 million times in the 4 years that it was operational, and it increased the number of prescriptions. So again, we also need to recognize that all these, tiny nudges, even when we have a clinician, a trained clinician on the other side of things, they still change behaviors. Again, the final responsible person is the clinicians that's actually acting on the suggestion, but there is a space for, we call these dark patterns of, inappropriate nudges. That's also
unfortunately, you're right that these alerts, they do work, they do change behavior, and not for such a dark example, but for another example, a mistake is made in the dose of a medication that's in an order set. That incorrect dose will be used. Mm-hmm. And you have a responsibility to check that as carefully as you can, because right or wrong, that's going to change behavior. I think when it comes to the final judgment is, of course, in the mouse finger of the ordering clinician. There is a temptation among some of my risk management colleagues to inundate that clinician with more information than can be absorbed. So in an effort sometimes to help prevent problems, we end up making them more likely to occur, just because you're giving so many alerts that you blow through them. And there are examples. There's one published, unfortunately, from Stanford Children's, where a child received medication that there was an alert to prevent against, but it was in a sea of these false positive alerts, and it was missed.
Yeah, absolutely. We have a couple of more minutes, and Ruth raised her hand. Go ahead, Ruth.
Hi, thanks for a wonderful presentation. I did my PhD at the University of Washington with Professor David Allen, and I'm hoping the cherry trees are flowering there with abundance. My question really is about whether CDSs can also have prompts around difficult questions or problems, for example, weight management or trauma or questions like that, and what you might know about how effective they are, about their effectiveness.
Well, I don't have personal experience with those domains, but that's an example really of things that happen to people, to human beings, that need our attention. And sometimes we're blind to it. We don't see the writing on the wall. We don't see the clues. And so I think that's a great domain for exploration and testing. And for all I know, it has been done. I'm just not aware of it. We have an example of a trial going on at the moment here. In fact, in this building I'm in, while I'm on the wards, I get alerts for considering having a discussion with a patient about their wishes toward the end of life, because the chart contains no evidence that discussion has occurred. And from the appearance of the patient's situation, there's severe illness that may not be easily managed. So this prompt kind of puts it in my brain to be thinking about that, where otherwise I might be distracted by the acute illness and problems of the day. So there's a lot more work to do, and the conditions that you're referring to are obviously very, very important to our health.
Thank you, Tom. And I know we're on, at the end of the seminar, but if you have time, we have one last question. Is that okay? Tom?
Yes, oh yeah, fine with me.
Okay, Kenneth, go ahead. You're the last question.
Oh yeah, thanks, thanks Dan. Yes, Tom, really enjoyed your talk. Thank you very much. Just a quick question. I really was struck by your example about the CDS, the alert, and how well received it was for the C. diff, alerts. I work in the NICU, and obviously it's a very small, specialized area, and I found that some of the more generalized CDS is actually not, it's not quite for us. And I was thinking about, obviously there's the commercial pressures about trying to get a CDF, an app, although the non-epic competitor has now moved towards an app market for CDS, I guess, and other apps. How have you seen this work in, more niche specialties in the US, for example? Has it led to more targeted CDS applications that's linked to a big, EMR platform, and how successful that's been for niche specialties, as it were, or rather very narrow specialties?
Very good question, because you give an example of a setting where the needs are very different than for the majority of adult patients. We do have some reason for optimism there. The FHIR standard is allowing us to take data out that might be used for CDS that we could tackle in that area. That's very important to us, but not to the majority of clinicians. Just 2 days ago, we launched our inpatient, I can say the vendor now, inpatient Epic, and we built into there the connections to Epic for a outside application that is very much part of our culture here called Cores. So, and it's got some bugs, it's got some problems, it's not working as well as we'd like, but it's there, and it's probably going to get better next week and a lot better the week after that. So these new standards are giving us hope that we can do this. This is new. This became a requirement recently in the United States that vendors support these standards. And it will be, I think, a movement that will help to address some of the problems that you're addressing. Is it Kenneth? Yeah.
Yep. Thank you. Thanks so much.
Thank you so much, Tom. So with that last question, we conclude our seminar for today. And I wanted to thank Tom for being here with us. You've been very kind. Your experience is extremely valuable. And we look forward to learning more from you in the future. Thank you so much. And I invite everyone on this call to look for the new, oh, there it is. So our next seminar is on April 15, and we're going to have Gretchen and Karen, Gretchen Piat and Karen Stahlberg from the University of Michigan for another great and interesting talk. So thank you everyone for participating, for sending out your questions, and we'll see you around. Have a great weekend.
Bye, everybody.